Welcome. Thank you. Tonight, you are at what we call a Compass to Care program, and we do these Compass to Care programs all around the United States because what we're doing is we're taking many different aspects about multiple sclerosis and presenting that to you. It's not only about the medications that you need to know about, there are just so many other things, of which some you will hear about tonight. For tonight's program, I want to thank two of the pharmaceutical companies who supported tonight's program with the educational grant. And that is a new player to the field named Celgene. Okay, you'll be hearing much more about Celgene in months to come. We do want to thank them. I hope everybody will say thank you. Thank you. Another one is one that has been in the foreground much of the last year plus, and that is Genentech. All right, and so we want to thank them as well. And of course, we want to thank those that were here tonight to exhibit and be here for you. For those that do not know, my name is Stuart Schlossman. I too have multiple sclerosis. Long story with that. You can see me about that later on if you wish, but we're not doing that right now. We do have three presenters to bring for you tonight, and we're going to get started on the first one very shortly. So tonight's program, though, we do have Jeff Siegel, and Jeff Siegel's a personal trainer. I'll speak to you about him in a minute. We do have Dr. Justin Koenitzer, who's a neuropsychologist from the local area, and we do have a local favorite of yours, and that is Patricia Pagnotta. So next we have Dr. Justin Koenitzer, and for those that don't know, he is a clinical neuropsychologist in the field for 9 years. His affiliation is with the Orlando VAMC, which I guess is Veteran Affairs, right? Okay, he's special recognitions. Dr. Koenitzer has several published abstracts and professional presentations related to the assessment of neurocognitive disorders as well as olfaction and neurodegenerative disorder. Dr. Koenitzer's clinical and research interests center on assessment and treatment of neurocognitive disorder to include traumatic brain injury, various neurodegenerative diseases, and multiple sclerosis. Let's welcome Dr. Justin Koenitzer.
Okay, sir. Have my timer. All right, excellent. How is that? Good volume? Good. And what I always like to do is just get a quick sense of how many of you, by show of hands, have been to this event before? Or one of these events with Stuart. Okay, so it's about, looks like about 50-50. And how many of you have heard a talk that I've given in some way? So even less, maybe 20%. That's good. I'll try to reuse some old tricks. So we're talking tonight about facing cognitive issues. Okay, as a clinical neuropsychologist, we could talk about a lot of things. I'm going to try to keep this focused on the cognitive side of the house, although we may meander into some other areas. Let's see, where are we going to get started? Let's get started with some of the facts. By the way, I think the word cognition is fairly well understood now, but if you heard it tonight a couple times with Jeff and you don't know what it means, thinking skills. It's the fancy word for thinking skills. Attention, concentration, memory, okay? Even if you're advanced in this field, you might have heard the term executive functions. So these are the cognitive or thinking skills that we're going to focus on relative to MS. A couple of facts. Cognitive symptoms vary among and within people. This is probably obvious to you. Everybody's cognitive symptoms, even if you have MS and your neighbor has MS, are going to be different. Okay? Interestingly, and you may know this as well, your cognitive symptoms, if you have them, within your own self are going to vary over time, depending on where you're at in your disease stage process. So there's a lot of variability there. The number one symptom complaint when we talk about cognitive symptoms seems to be memory issues. Okay? As Jeff highlighted, and I think this is really important, fatigue is also very common. I read a lot of research day in and day out, and I read the research on the research. So I look at meta-analytic studies, studies that study multiple studies. And you get closer and closer as you funnel down into the data, and it looks like over 90% of people with MS complain of fatigue. I'm surprised it's not 99, but somewhere over 90. Tricia may be able to help us with that statistic later, but it's prevalent, okay? Where does that fit into cognition? Again, if I'm trying to keep this talk very specific to cognition, we're going to come back to that idea in a few minutes. 45 to 60% of individuals with MS will go on to develop cognitive impairment. And we could talk about this all night long. How do we define cognitive impairment? Suffice it to say for now that although 45 to 60% will develop cognitive impairments, only about 20 to 30% we find will develop significant cognitive impairments. We could talk about it in terms of dementia, if you've heard that term. I like to keep it just to more significant or more major cognitive impairments. It's a small proportion, believe it or not, okay? Relative to the fear that one might have when first diagnosed or looking at someone else who has MS, it's relatively low. And I want to focus you on this last statistic. If you can't see it because of the cameras there, it says 40 to 55% of folks with MS are free from cognitive impairments. And again, maybe in Q&A we can talk about these numbers. That's not necessarily over the lifetime of the disease, but that's at any given time looking at a whole bunch of studies at one time. Okay? It's pretty interesting that cognitive impairments, I think the take-home message is not an absolute with MS. It's not an absolute. Now, I also need a volunteer. Today's a volunteer. You guys are going to get a workout. But in reality, though, here, I don't need a volunteer to come up. I need you to stay in your seat. And I need someone to raise their hand as a volunteer, particularly someone who's okay with getting something wrong. I'm going to quiz your memory, and I want you to feel okay about not doing so well on the test. And this gentleman, I'll get you for another one, but this gentleman here has raised his hand multiple times while Jeff was doing his talk, so I'm going to go with it. In case the camera gets you, you can stay in your seat. Can you do the wave and wink that you're okay to be on camera? Okay. And do you mind sharing your name just because I'll have to go? Alex. Alex up front is going to be our volunteer. So Alex, I'm going to test your memory, okay? Simple question first, and don't help him. I walked right past you to come up here, okay? I have on the back of my coat a round sticker, about this size. Was the sticker, what color was the sticker? I didn't notice. Okay, before you try to answer, I'm going to give you three choices, okay? The sticker was either green, navy blue, or red. And I want Alex to give us his best guess. He can't say nothing, or I don't know. Give us your best guess before we give you the answer. Green. Okay, Alex says it was green. Think about that. Some of you who may have seen the sticker, think about that, okay? Green. We're going to come back to that. Before we come back to that, you can't see it up here. It got cut off. My apologies. It says a model for thinking about cognitive impacts on MS. And Bill, I can walk around with this, right? It's easier. As long as I hold it up top, right? Okay, still got me. A model for thinking about cognitive symptoms in MS. I think one of the biggest misunderstandings with cognition is in particularly related to memory, but also all of cognition. People aren't really sure how it works. And I'm going to give you a very oversimplified model, and I don't want to bore you with the details, but the point will be for later when we want to talk about treatment. Because y'all came to get some ideas on what the heck do we do with this thing called cognitive impairment in MS. We've got to understand the model before we understand what to do with it. So this is Stuart. He let me take a profile of his face earlier. He wore one of those things that makes your hair go back because he fears one day it might be bald. So we got a picture of Stuart in profile, and we got a picture of his nice-looking brain we could see inside. So this is you, okay? And this is the world outside of you, okay? Everything, reality, your job, your people, just everything. Imagine that with me, okay? Cognition or memory is not a thing. Does It's not really a thing. Instead, it's a process with multiple steps to it. The first step of cognition is to be aware that information is always coming from the world into you. Okay? And it mainly comes in through what you see and what you hear, but it comes in other ways too. But we like to think that what we see and what we hear in the world is the starting point of cognition. Then, the information that we see and hear, call it information input, travels back into our brain, and this little swirly thing up here, that is to represent brain processing. Okay? So we have things going on deep within our brain that process information like a computer does, and they do something with it. What happens after that? The third and final step of this model, and it's a very oversimplified one, I said, output. It's got to go out somewhere. Information output, or what we call memory or even knowledge. So walk through real quick again, simplified. Information input from the world through our sensory systems, our eyes and our ears and other systems, gets processed around in our brain, very complex ways. And then at some point I say, Alex, put some information out. I'm going to test you. I want you to tell me what color was on the back of my jacket. And he gives me an answer. He gives me a memory, what he remembers, his best guess. I ask him, who was the first president of the United States? George Washington. He gives me knowledge. But guess what? That knowledge had to start somewhere, way back at the information input. He had to read it when he was a kid. He had to have someone tell it to him early on, right? It had to go through that process. It didn't just exist there. Okay, so you follow, right? So if this is our working generic model of cognition, and we want to zoom in on cognition in MS, guess where problems might occur? You're thinking exactly. You know, most people think it's a brain problem or a central nervous system problem. It has to happen with brain cells and myelin sheath. Not really. Problems can happen anywhere in this model. And in particular, in the three areas, information input, there could be a problem. Brain processing, there could be a problem. And information output processing could have problems to it. If there's problems in any one of these three areas, you are going to demonstrate cognitive weakness. What are some of the problems with information input, that very first stage? Rhetorical questions here. If you're not paying attention to the world, what kinds of things get in the way of that? Fatigue, depression, and I'm talking about the emotional depression, anxiety, pain, sleep disturbance, and there's more. The list goes on. So what I'm saying here, guys, if it's not obvious, is that any of these major suspects that might interfere with your ability to fully attend to the world are ultimately going to have an impact on your cognition. It's not just damaged brain tissue that causes cognitive impairment. We'll learn about why as we go on. What kinds of brain processing issues could cause cognitive or memory impairment? Well, you could have neural damage. That's the one everybody knows. Your brain cells deteriorate or in some way are turned into scar tissue over time or inflamed. Or medication side effects. Okay, now we're zooming into MS. So if you're taking meds for pain, you're taking disease-modifying agents, you're mixing and maybe a mood medication, some of those medications can cause cognitive side effects in and of themselves because they're dealing with brain chemistry. And then finally, information output. Issues with that can stem from anything. You're pulling it out. So if it didn't go in clean, how are you going to pull it out clean, right? I tell you this because you cannot address the cognitive impacts of multiple sclerosis without addressing the emotional impacts. They go hand in hand. You really can't. You can try, but it's difficult. So real quick, I promised you we'd stick with cognition, but let's run through these statistics here. Approximately 30% of individuals with MS report depression. Is actually up over the lifetime of living with MS. It's around 50%. We call it lifetime prevalence, meaning throughout your entire life, there's 50% people with the disease get depression. Two types we'll come back to, this reactive idea versus the direct consequence of the disease. And the difference there is a reactive depression is like when you learn you have a diagnosis or you learn you're headed into a relapse and you react to that. You're upset about it. You know the effect it might have in certain areas of your life, and so you become depressed. Versus the second one, the direct consequence of the disease, has to do neurochemically with where your lesion or your lesion load might be, can give rise to a depression. And we'll spare the technicalities there, just so you know. Anxiety is another not so uncommon mood symptom. There's so much uncertainty in MS. When is the next relapse going to come for some folks? Am I going to be able to ambulate with a cane for the next 20 years, or is it going to have to move to something else? What? Always asking, what's the next thing? It's very anxiety-provoking. Uncertainty. And then finally, and these emotions typical of grief can happen at any time. They typically happen actually when a young person first gets diagnosed, because they start dealing with the idea of loss. These emotions about grief have to do with loss. You hear them if you study this stuff. Elizabeth Kubler-Ross, you hear about it with death and dying when you lose someone. Well, guess what? You could be thinking that you're losing versions of yourself. I'm going to be different now because I have MS. And so you actually do or can go through the process of grieving the loss of another version of you. And when you put all this in a pot and mix it up and stir it up good, you could really start to ask yourself, well, who am I? Right? And have some struggle with this idea of self-image. Just an aside here real quick, we know from other social science research, this is different research, that how you see yourself can in part be related to how you think others see you. It gets really complicated. But if you're walking around in Walmart and let's say you have an ambulation support, two-wheeled walker or something, you may think that the world, people in Walmart, are thinking of you in a certain way, right? I see some heads nodding, by the way you look. And then in turn, you may try to do something different about yourself or just think about it or whatever, but it affects you. And if that happens everywhere you go and every place you go, guess what? How you think others think of you begins to change the way you think of yourself. So is this a vulnerability? It could be. We're shifting into talking about, I want to be heavy on treatment here tonight. So let's start the shift now. Is this a vulnerability, or can we start to think of this as an opportunity? We have an opportunity to redefine our self-image with MS. We really do. And this piggybacks on what Jeff was leaving you with. Taking charge of your life with MS. So what can be done about these? I'm going to go back to cognitive issues and the mood issues that are part of it. What can we do about it? This is a little cliche, but I want you to really think about this, okay? Why not start overall, before we get into the specifics of what we can do, just start with a perspective of focusing on what you can do as opposed to what you can't. In the physical exercises that we just witnessed, the whole process was one of Jeff showing you that if you keep doing it over and over again, your form, your strength, it gets a little bit better. And he only had 5 minutes and you only did a couple reps. But you can do stuff. Or you could sit in the back and say, I don't want to volunteer because I can't do that. It's kind of a choice. I'll tell you one more anecdote about how we talk about this in the science. You know, I go to work every day and do this kind of stuff. You may have heard the term reframing, focusing on what you can do and what you can't. What that means, if it's not obvious again, a frame is something that goes around a picture, right? And if you hold up an empty frame, and I go back to Stuart. Oh, he's going to not like me for that. He's not in the room. Patricia, is he back there? I don't see him. Okay, so, right, you can. Oh, there he is. Well, I'll say it anyway. If you hold an empty frame that you can see through up to Stuart, you're going to get a certain picture. It's going to evoke a certain mood in you, a certain something. It's Stuart. Most of us know Stuart. Now, if I reframe the picture or the situation and I carry my empty frame back there to Tricia, Tricia, and I hold it up to Tricia, and she's beaming and she's waving at Stuart, and we change, we might all go out of here in a what? You say it, not me. Somebody said a better mood? Oh, I don't know about this crowd, Stuart. But you get the picture, right? We can change the frame, and by changing the frame, we're encouraging the viewers, whoever they are, to include ourselves, to look at something different. Look at it different. And the effect it has on us as frame changers is it could change the way we feel. It's really simple, right? It's harder to do. So let's spend the last few minutes and I'll give you some examples of how you might try to do it. So, one more anecdote, okay? I talk abstractly, I realize. But if you walk out of here and all you remember from my part of the talk is this world and what's going to come next, I'm okay with that. At least you got that part. Close your eyes if you'd like or leave them open. But I want you to play a little mental exercise with me. This globe, this world is very big. And I'm going to tell you, unfortunately, that all the land mass on the entire globe is that slippery concrete stuff. Home Depot floors, or I don't know. Think of, you know what I mean, where it's a big slab of concrete, but it's not been worn in yet, and they polished it. So you're walking along, and it's troublesome. The likelihood of you going about your day and not slipping and falling and injuring yourself is low. You're gonna get hurt. Now, if you can do this with me, kind of a metaphor here, imagine that that slippery concrete world is your MS. It's not a danger in and of itself. Slippery floors aren't dangerous. It's a potential hazard. Depends on what happens on top of it that could cause the danger. And every day I meet with at least one person with MS every day and talk to them about these things. And I say, so from the start, before we get into your plan about what we're going to do, you have two choices. This is the way I frame it. And I only give them two, right? They could have 18, but I say you have two choices. You could go out and recarpet the entire world. Roll the carpet out and cover all the land mass on that planet with carpet. And guess what's going to happen? No slipping, right? This is good. Guess how long it's going to take you? Your entire life and another life and maybe 4 over that. It's an impossible task. So in the metaphor, it's very unlikely that you're going to change the MS right now. I like when Tricia talks and some of the neurologists to remind me of the latest and greatest disease-modifying agents, but the likelihood that you are going to change MS in the work that I deal with right now, its core of what it is unlikely. What's a much easier thing that you can do to deal with this problem? Why not get a nice pair of sneakers with really good traction on the bottom, like these New Balances? You can see the little grids, and slip them on. Hey, $50. It's not going to cost you 4 lifetimes to go out and carpet the world. Now you can just walk around on the slippery concrete all day long and not injure yourself. Right? So there are things you can do for these seemingly insurmountable problems that don't necessarily eradicate the problem, MS, but can help you function in a world where the MS is present. Sorry, that's a brief case. It didn't translate well. But if you're getting this and you're thinking there's some usefulness to this idea, I would encourage you, I don't know how many of you work full-time jobs or where your work status is. Some may be disabled, retired, still working, whatever it is. Imagine that your MS, I tell this to people first visit when I'm dealing with MS, is a job. It is, yep, and look, good. Many of you are already there with me, right? Because I'm listening to Jeff, I've listened to Tricia numerous times, I've listened to at least 8 or 9 different speakers at these events, and I get so much good information. And I don't have MS, but I imagine sometimes walking out thinking, how the heck am I going to remember that? How the heck am I really going to do that, what she said to do, what he said to do? And when I start to think about, well, if I approach the whole situation as like, this is my job, it increases the likelihood that I'm going to maybe bring notes. I'd bring notes to a job, bring a notebook when I hear Patricia next time. Sorry, Tricia. Bring a notebook. Ask one of my family, hey, write that down. Follow up when I leave an event. Go do some research. Pull it together. Have a weekly schedule. My gosh, that would be novel, right? Where you sit down at the table, spend an hour just organizing what you're going to do. Apply it to your exercise like we saw. I'm going to slam that ball for 10 minutes every day until it starts to feel comfortable. Then I'll do it for 15, 20, and so on, right? So make it a job, and you will succeed that way. I only have 5 minutes to run through some specifics, but I could never do cognitive therapy to help cognitive issues with a group of you in 30 minutes anyway. So let my job tonight be to plant these seeds, and you can follow up with me or anyone else if you want to learn more about what they are. First are some obvious ones. Be open to the extent that you feel comfortable with the workplace, by the way. Not if you're not ready. Comprehensive treatment. Tricia's going to talk all about a team and when to let players in and who to involve and how that works really well. So I'm going to leave that to her, but think about that. Remember how I said you can't treat cognitive issues without addressing the mood piece? Because we know attention is the first step of cognition. So by comprehensive, I also mean don't say, I have cognitive problems, I give up, without addressing all the other things that might contribute to those cognitive problems. And then we already heard, this is so nice because I can just follow up from Jeff. Exercise, he said everything right. There's new research. Exercise brings blood flow to the brain. Anytime you have blood flow to the brain, you're bringing oxygen and glucose, and that's what cells need to function. That's their food. So it's not going to hurt. The only thing that's going to hurt is if you try to do an exercise you can't do and then you hurt yourself. But anytime you can get blood flow into the brain, it's going to help. Tons and tons of research. The whole world of cognition and rehab is now focused on exercise and in the literature. It's amazing. Watch out the next 10 years, we're going to get some really good stuff with exercise. For reasons we don't understand well, there's a couple of thoughts I have on this, but believe it or not, social connectedness improves cognition. It's a weird connection, I know. But as Jeff was nicely picking up on too, he likes to do his exercise in ways that are fun and maybe bring people together. Because he's probably been reading the literature like me, and he's starting to realize there's a value to that. There is a value to social connectedness for increasing cognition. One of my thoughts for the more complex thinkers out there that want to really know, that's weird, why is that? Well, when you're social, you're conversing with other people, right? When you're conversing with other people, you have to pull forward language if you're talking. When you have to pull forward language, you're activating language centers of your brain and the frontal lobes to bring the words out. It's like exercising your brain. So that's one of the lines of research into that social piece for cognition. It's amazing. Medications, I'm going to be real quick here because I have to tell you, both disease-modifying agents that have been thought of as possible cognitive enhancers, as well as what we call cognitive enhancers for things like Alzheimer's disease, Donepezil. There's just mixed literature and not a lot of it at this point. And again, maybe in the Q&A we can get more into that. I'll leave it at that for now. Tricia may also have some thoughts, but not compelling for treatment for the cognitive issues. Now, the last piece here, cognitive rehabilitation. We know the term in the field, at least, in terms of like inpatient stroke rehabs. That's where it got its clout, and that's where we do a lot of cognitive rehabilitation. It really works in acute care settings after people have injuries. They have a stroke, we get them into physical, OT, PT, and cognitive rehab, and it seems to help. For MS, it's less clear, and for non-acute conditions like TBIs, traumatic brain injuries that happened a long time ago, it's less clear. There are two types. There is this idea of a restorative approach, and by restorative, what we mean is we're trying to restore your brain functioning as close as we can to the way it was before the disease wreaked havoc. Based on these ideas of neuroplasticity, that brain cells will reconnect to other brain cells to work around the problem brain cells with repeated use. A lot of repetition in there, okay? Graded practice, what Jeff was doing with you physically is the same thing I would do with you in a cognitive rehab session relative to cognition. If your attention skills aren't there and your information processing speed is slower and you feel that, we would start you slow with an exercise. Okay, I want you to read this passage, I'm going to time you, and then we would amp it up another level, do it again and again and again, and I'd send you home with homework. And you'd have to be committed. But why are you committed? Because you made this your job, remember? So you do it, right? Okay. And then there's some computerized programs that really are developed around the graded practice idea that you could see a therapist and work through. And I have 30 seconds left. So here is the main stuff that I do for my work, and I love this because it meets you where you're at. This is the other approach to cognitive rehab called the compensatory approach. And basically the idea here is we're not necessarily concerned with restoring brain cell function. We might get a little of that as a side benefit, but we want to work around the problem as it occurs in your life to increase quality of life and improve your thinking skills for day-to-day functioning. So for example, I see someone who is very forgetful. I go out of the house, wife gets mad all the time because I forget the groceries, I forget my keys. So a very simple idea as a workaround is we've created a memory bowl. He puts the bowl in by the front door, and wallet, keys, glasses, everything that he needs to go in and out of the door, grocery lists, are centralized there. So he doesn't have to remember where he put his keys and walk around the house 15 times. Do you see how that's not necessarily restoring brain function, but a strategy that can help him work around that problem in his life? That's a very low-level, basic intervention strategy. And when you meet with a cognitive therapist, if you think this is interesting to you, or a neuropsychologist, the plan would be with this stuff to develop a very individualized plan for you. You may have more sophisticated problems and needs than someone else. And so we would work to build that plan to help you function with your cognition better. That's the main idea. And I think on that note, I am done. It's just a reminder that it's your job, and don't try to carpet the world. Put on those sneakers. They will help you navigate much better and more inexpensively.
Awesome. Thank you very much. Thank you. Did a great job. Can't wait. By the way, for anybody that was blocked from seeing the screen, just remember, though, that we're video recording, so you'll be able to watch it again and go through everything. But let's thank Dr. Koenitzer for being here. And next we have Patricia Pagnotta. And I know it's getting late, but after Tricia speaks, we're going to do a Q&A. So we hope that you stick around and you can be here for questions with both of them. So Patricia Pagnotta, she's currently employed at the Neurology Associates, PA at the MS Center of Greater Orlando in Maitland, Florida. She was named this year, she's the president of the International Organization of MSRNs. I think that we should give her a great round of applause just for that. Okay? It means a lot. It means a lot because I attend a lot of the conferences, and I'm so glad that I see the turnaround in the International Organization of MSRNs every year, and I think it was great when I heard that Patricia was the current president. So I'm glad that she's here. And Patricia completed her undergraduate degree at the Towson State University in Towson, Maryland. She's a graduate, was completely at the University of Maryland, and she did postgraduate work at the University of Central Florida. She's an active member of the MS community. Currently, she serves on the executive board of the International Organization of MSRNs, as I said, and she's a member of the Consortium of Multiple Sclerosis Centers. Tricia published in MS in peer-reviewed journals and patient. I'm having a hard time reading right now, aren't I? Oh my gosh, here we go. Tricia's been active in research as a primary investigator and co-investigator on several clinical trials in multiple sclerosis. Let's give a round of applause and welcome Tricia Pagnotta. My reading skills are horrible. You want that one?
So since I'm not going for a job interview, I usually don't ask the persons read all those things about me. I hope to share with you some good thoughts. And every time Stuart asks me to talk, I feel like the talk he gives me, I could spend days talking about, and he gives me a small hunk of time to talk about. So question and answers afterwards, please stay around for those. So comprehensive care, what is that? It's patient-centered approach with interventions aimed at minimizing suffering, maximizing function, and reducing costs associated with complications. So when we look at the goals of comprehensive care, improve care, clinical outcomes, the quality of life for those affected by MS, accompanied by timely access to care, an accurate diagnosis, successful disease and symptom management, to meet the individual needs of persons and families living with multiple sclerosis, promote quality of life, adhere to cost-effective outcomes, advocate for services and resources, and interdisciplinary approach to a plan of care. So we know that this disease is extremely complex, and there is a approach to this, and one is modifying the disease course. The next is treating relapses, managing symptoms, promoting function through rehabilitation, providing emotional support, and a focus on wellness. So the new vision of MS is to give persons a greater understanding of the disease, because just as we want you to have a greater understanding, we have gotten a greater understanding. New therapies have emerged because of this, and so using those new therapies, the emergence of a new philosophy embracing action, early intervention, hope, and an empowerment. So again, moving forward, prevention of relapses, MRI activity, and disability progression. As many of you know, that's one of the things that I report on as person's report card for MS. The acute symptomatic, sustained, and rehabilitative care, which includes rehabilitation therapies, psychosocial care, long-term and palliative care, and then a wellness approach incorporating other symptoms of care, primary services, preventative measures, and focus on education. The MS team may be found in centers, and maybe some of you go to centers, but they can be in community practices, and they can be in centers without walls. So moving this philosophy really, hopefully, should be occurring in many places. So the Consortium of Multiple Sclerosis Centers defines comprehensive care as embracing a philosophy of empowerment in which persons with MS take an active role in planning and implementing healthcare and self-care activities and acts as a consultant to the team. This is active rather than passive role in fitting in the light of the fact that MS, like all chronic illnesses, is expected to last a lifetime. Persons with MS must learn to adapt, change in response to alterations in their physical functioning. So that might be something different than you have ever heard before. So when we look at the multidisciplinary team approach, you see here, it's extremely important. I tell persons when they come in my office, it's all about you. And it truly is. The person who is living with multiple sclerosis is truly in the middle, and all services come out from there. And so I separated out the nurse and the NPPA, and then you have the neurologist, psychiatrist, psychologist, neuropsychologist, social workers, urologists, speech pathologists, vocational counselors, neuro-ophthalmologists, orthopedists, occupational therapist, psychiatrist, primary care, and physical therapist. And so all of these approaches, all of these, maybe one person needs some of these, maybe one person doesn't need any of these. If you do, then you must not have MS. So if you think that you don't need any of these, if you can't put yourself in the middle and think of at least 3 or 4, probably 5 or 6 things that you might need now or might need in the future, then you really need to spend more time with your team and trying to figuring out why you can't see that you really need all of these services. So a treatment focus looks at educating persons, making sure that you have what you need to be that active member. Obviously, there's disease management, and the key really is early treatment to delay progression. Symptom management, if we don't manage symptoms, then persons are not going to be happy to come back and see us. Again, all of that focusing on wellness and bringing persons to a better being. In educating persons, it's extremely important that you think about, well, I really need to have basic information about MS. How is it diagnosed? How am I sure I truly have MS? What is happening in this process of MS? And who gets MS? And so when you understand what is happening, that might better help you understand disease-modifying therapies, the symptoms that you have. But it's extremely important to be aware of what are the symptoms that are most common in MS and what are some symptoms that might not be MS. Be aware of treatment options, and it's extremely important when you think about treatment options. I tell persons, you know, it's got to be something that is sustainable for you and is working. If it's not working, then it doesn't matter that maybe you like that therapy, but if it's not working for you, it's not helping meet your goals. So be open to things. Have realistic expectations. I can't tell you how many persons believe or think that I am going to be able to take away what happened to them 10 years. And at this moment in time, I can't. I pray for that every day, but I don't have that ability now. And so the best thing, again, is to be realistic in what we can expect and to reinforce this education at every visit. So every visit you come in, make sure that you have an awareness of these things, and if you are not aware, then ask questions and get information. So this is the natural history of multiple sclerosis. We see this in just about every professional program I've ever been to, and it still is extremely relevant. And so persons, I like to make sure that persons understand the risk of this disease, MS, because when I talk to persons about things, whether it's disease-modifying therapies, symptom management therapies, or even physical therapy or personal training. Persons can very quickly come up with, well, why they shouldn't do that or what might be. But there is a risk of this disease, and persons really need to embrace that. And so we know early on, oftentimes, there's a silent phase of multiple sclerosis where we are not seeing the person before they have had several attacks. And you see on the bottom here is attacks that have happened on your MRI. Most persons, when we have this initial event that brings them in to see us, they've already had accumulation of attacks on their MRI. And then again, in the relapsing form, where 80% of persons are diagnosed, there are these clinical attacks where persons have relapses, but also in that there are these silent attacks where, despite the fact that they're not having relapses and they feel like they're doing well, we can still find attacks on MRI. We can still see disease activity. So again, being an active participant, when you look at this model, that means that you need to have regular MRIs because we know that there are silent things that can be happening along. We know all along, as this line here shows, that there is a progression of disability over time. And so even in the earliest phases of multiple sclerosis, we know that there is some degeneration that is occurring, but at some point that pendulum swings to having more degeneration or less neuroplasticity, and you start developing more disability. So you want to stay down here as long as you can. Natural history tells us that persons in 10 years that go untreated, more than 50% of persons will progress to secondary progressive. And so at this moment, this might be different next year, but at this moment in time, we don't have an FDA-approved treatment for secondary progressive. So if I label someone with secondary progressive, your insurance company is going to say, you can't have a drug. But beyond that secondary progressive, you see there's more disability and less clinical attacks. So if you had to pick somewhere on this pendulum where you wanted to be, most people would want to be over here. But if you're here, you want to stay there. Natural history says you're not going to do that without a disease-modifying therapy. When we look at treating persons, so everyone that does anything with MS knows that the earlier we treat, the better off persons will be. If for some reason we don't start treating persons early, we are never able to catch up. So we've proven that in study after study after study. So really, at time of diagnosis, persons should go on therapy. And so I try at time of diagnosis to give persons lots of thoughts, and they probably leave my office very overwhelmed, but they come back very quickly. You don't leave my office at being diagnosed and say, I'm going to see you back in 6 months. You know, read all this stuff and I'll see you back in 6 months. No, you need to come back quickly. We need to get you on therapy. And again, that's to keep you from progressing. So that's extremely important. So when we talk about symptoms, symptom management, again, generally symptoms are motor, sensory, emotional, or cognitive symptoms. Symptoms may remain, they can fluctuate, they can get worse. We talk about symptoms in 3 different realms. Primary symptoms are the symptoms that we can say are definitely occurring because of the lesions that we find on your MRIs, what we can see. So fatigue, believe it or not, that's short-circuiting because of those scars. I move my hand very freely like this because I don't have any scars in my brain where my brain is having to recircuit and try to get this arm to move. And I don't have any scars that is causing my hand not to move nicely, or I don't have spasms and I can't move my arm because, oh, it got stiff. I don't have any of that. But you might, and that would be primary symptoms. Now, secondary symptoms are symptoms that occur because of the lesions, but they're not a direct result of them. Things like falls. Well, you become deconditioned, you aren't working very well, or that slide board you can't get over, and you're more likely to fall, and that's a secondary symptom. Urinary tract infections, things of that nature. Tertiary symptoms are really more psychosocial things. Losing your job, losing a loved one through divorce or separations. So those are the type of symptoms. But all of those symptoms need to be managed and need that whole team of individuals to do that. So again, thinking about new symptoms, that could be a relapse, but it could also be what we call false relapse or pseudo-relapse. Remember back the slide where you had all those attacks that were happening and you didn't have anything different. If you go out in the sunshine here in Florida and you have never had blurring of your vision and you get really hot, you might have blurring of your vision because most persons that have multiple sclerosis, the shortest nerve in your central nervous system is your ophthalmic nerve. And so you can have thinning of that retinal fiber layer, and you may never have had an optic neuritis, but heat comes on and suddenly you're having blurred vision. And it doesn't last for 24 hours, but you've never had that before. That is not a relapse, but it's still something that you need to be aware of. So when we look at symptoms, it's all about location. Where are you having lesions? And again, not only where are you having lesions and where symptoms might be from, I like to explain to persons why are persons so different? Why is it that I can't say, okay, you have a lesion here and this is going to cause you this symptom? Well, yes, we know what territories do, but we also don't know any one person's individual ability to make a new way, a new pathway, and depending upon how long you've had MS or how many attacks you've had, your brain may not be able to reconnect. So I tell persons to think of that funnel. So big, large funnel way out here at my fingers. If I have a lesion out here at the top of the funnel, it's not going to cause as many symptoms as if I have a lesion where the funnel is getting more narrow. And then not only the out here at my fingers might be perfectly fine. My whole arm may be perfectly fine. Again, speaking, this is my brain. But as we get deeper in your brain, all of the networks have to come down through there to go out. So again, it's a networking system. So it's not that we don't know where things can be, but the network, the moving of electricity through. So when we look at symptom management, optimal symptom management means that we use a multidisciplinary approach that can maximize the outcome for persons with multiple sclerosis. We use both pharmacological and non-pharmacological interventions and are really looking at a very broad spectrum of things, and that we reassess and adjust because most things I can't say, well, this will, but we have to be open to, okay, let's, start here. We always want to start, if we're using medications or even non-pharmacological therapies, we want to start at the lowest level and then move upwards. And so it's a constant readjustment. So it's important to be patient with that. When we look at the common symptoms of multiple sclerosis, fatigue is number one. I don't know of any person with MS that has not. So I would tell persons that fatigue is 100% because at some point in your life with multiple sclerosis, you're going to have some times that you're a little more fatigued. Now, is that primary fatigue? Is it something from the lesions or is it secondary from other things? But I can guarantee you will not be a person who goes without some fatigue at some period of time. So thinking about that. Depression, it ranges anywhere up to 60% for persons, and some of the disease-modifying therapies can actually make that a little bit more problem. Focal weakness, visual changes, bowel, bladder, and sexual dysfunction, gait problems, spasticity, and paresthesias, which are sensory issues. So when we look at symptom management, again, I'm big brush strokes of things to tell you about, but bowel and bladder, management is looking at possibly changing your routines. Now, they had coffee in the back here tonight. And so coffee is a bladder stimulant. So if you have to sit through an hour lecture and then the question and answers and you don't want to get up, you might not, if you've got urgency, want to have a cup of coffee because, your bladder may not even be full, but you've drank that cup of coffee and all of a sudden it's saying, okay, gotta go. There are medications that we can use. Catheterizations, enemas, and suppositories are all good things. But again, I would tell you that in that changing routines, working with your diet is extremely important. Cognition, Dr. Koenitzer covered that very well. Depression, again, counseling, medication, and I would tell you that exercise is one of the best ways to elevate your mood. Looking at fatigue, persons, when they tell me about fatigue and I tell them that they need to rest, exercise, and maybe then we'll think about medicines. When I say exercise, they're like, did you not hear me? I said I'm tired. And when I say rest, I can't tell you how many persons say, I sleep very well. Well, do you wake up and you're satisfied? Do you wake up with energy? You should wake up with some energy if you slept very well all night. So if you wake up in the morning and you feel like you went to bed, there might be a sleep issue. And so being open to that. Mobility, physical therapy, medications, and there are lots of devices for that. Again, we only have one drug therapy for helping persons with mobility, and that's Ampera. When we look at pain, there's tons of therapies for pain, medication-wise, orthopedic mechanical devices, acupuncture, biofeedback. Again, it's important to recognize these symptoms and have a discussion with your team about this if you're having these issues. So paroxysmal type of symptoms, medication, orthopedic devices, acupuncture, they're all listed up there. We don't use a lot of steroids outside of relapses. I know a lot of persons will ask for that, but I don't use a lot of steroids because of the risk of problems with steroids. I reserve that really for relapses. When we look at sexual dysfunction, again, there are many things that we can do for persons to help with sexual dysfunction. But one of the biggest things is I can't help if I don't know you have a problem. And even if I ask, there's some people that just will not tell me. So please, if that is a problem and you don't feel that you can talk to me about that, then let me refer you to someone and you can ask for that referral in a different way. But please recognize that that is an extremely important part of your being. And sexual does not mean sexual intercourse all the time. So again, being loved and being able to love someone else is extremely important. So again, please make sure that you have a discussion with your healthcare provider about that. Spasticity, again, the biggest thing for spasticity is stretching. Stretching, staying limber. If you have a lot of spasticity, think about stretching before you get out of the chair. Don't just jump right up because it's that quick motion that you might get that spasticity. So try stretching a little bit before you get up. Range of motion, weight-bearing exercise, and then there's a ton of medications. We can actually cut tendons to help with that, block nerves, a lot of different things. But again, that's moving up after you have failed many things. Speech therapy problems, as far as with cognition, speech therapy is extremely helpful, but also with swallowing. And there's lots of exercises you can do to help build the muscles in your throat and your lungs to keep from having swallowing difficulties. Tremor medications, and there are certain procedures that are easy. Now, CAM therapy has become something that is extremely popular for persons to talk about, and that, I think, is one of the benefits that I would tell you about medical marijuana. Because persons have really, because of that, started looking at, well, what other things? And I would tell you that you should embrace complementary medicine. And so what is complementary medicine? Well, being healthy, eating right is complementary medicine. Exercising is complementary medicine. But other things like acupuncture, meditation, hypnotherapy, massage, chiropractic care, and there's a whole slew of herbs here and things that I am not going to tell you that there is scientific evidence for this because, like, despite the fact that it's up here, ginkgo biloba, there's no scientific evidence for the fact that that helps with memory. That being said, I have several persons that tell me it works for them. So if it works and it doesn't hurt you, again, that's something to think about. So when we look at the statistics in complementary medicine, it's interesting to note that 42% of individuals in the United States will use some form of complementary medicine, and that there are 629 million visits where practitioners that practice alternative medicines. 20% of persons will take some type of herb or vitamin in addition to their prescription medication. Startling, 50% of persons using CAM therapy are not going to tell their clinician about that. That floors me. I keep looking for that number to go down, and despite the fact that we tell persons that that number still has not dropped. If you are doing something complementary, please make sure that your healthcare provider knows, because again, as long as it's complementing your therapy, that's great. But there are some times where it may not be. So it's important to have that discussion. And it's interesting to note that, again, women are much more likely to use complementary medicine than men. And isn't that wonderful that MS is more common in women than in men then? All right, so the role of your healthcare provider in complementary medicine, you know, please, your healthcare provider should be asking you about over-the-counter medications. And so make sure, should encourage you to talk about that openly, should encourage you to use conventional therapies first and truly to use complementary therapies as complement, and be able to educate you about at least what they do know. We know that these are not FDA-approved therapies. Some side effects are unknown, and 99% of herbs are immune stimulating. So that is something you need to have a discussion with your healthcare provider about regarding the therapy you're on and what your complementary therapy may be doing to affect your therapy. So it's important to just have that discussion with your healthcare provider. So I hope that you guys can see it better than I can see it up here. Oh, I'm so sorry. So the cycle of symptoms here this is like a rat on a wheel. And so here you've got fatigue, depression, exercise, spasticity, constipation, bowel, bladder problems, sleep, cognitive function. All of these things could be happening, or maybe one or two of these things can be happening. But if you don't treat that, then you're more likely to get into having more symptoms occur. So one begets the next, begets the next. So if you are not sleeping well, you're more likely to have cognitive difficulties. And then you might have more difficulty with your bowel and bladder because you're using coffee and other things potentially to keep you awake. If you're fatigued, depressed, you're going to have cognitive issues. You might not exercise because you don't feel the energy. You feel weighed down. You can't get out. That will then increase your spasticity. So to think about your symptoms, that you need to identify what they are, talk to your healthcare provider, get into a full team of managing that, because if you can just do one thing, if you've got a lot of symptoms, and it may seem overwhelming, I know that this is an overwhelming disease, but think about what is the one thing that I can do for myself. And maybe I can just get up and out of a chair. I can do up and down, get out, in and out of a chair. And maybe I can't do that, but maybe I can sit in the chair and bring my legs up and down and my arms up and down. Jeff showed some really good exercises. So do think about what it is you can do. And sometimes all you can do is try to put your mind in a different way. Reframing. Is it 20% bad or 80% good? So there should be a wellness focus in comprehensive care, and this should be personal, multidimensional, and holistic, and this involves physical, nutrition, fitness, positive lifestyle habits. Emotional would be stress management, acceptance of limitations, and expressing your feelings. Intellectual, learning, continued growth, and new challenges. Occupational, finding a calling. At one of the lectures at CMSC this year was a lecture that was done that showed actual brain changes in persons who did not have a calling, a purpose for being. So they looked at a group of persons who had MS, who their disease was modified well as far as a disease-modifying therapy, but the only thing they didn't have was purpose or calling, and actually had changes on their MRI, functional changes on their MRI. So I encourage you to find that thing that makes you get up and move around. Social function, intimacy, respect, family relations, and tolerance. And then spiritual dimensions, whatever that is, whatever your purpose, your higher being is, to, again, look at all of these things. This is what makes wellness. So in multiple sclerosis and wellness, it's very important to avoid bad behaviors. Bad behaviors, smoking. We know that smoking makes MS worse. We know that persons that smoke are going to progress to a more progressive disease faster. Alcohol and drugs also don't do anything for your brain health, so please be careful about that. Develop a health maintenance and management plan with your care team. Make sure that you're screening for other health problems. MS is rare, but there's a lot of things that are much more common. Heart disease, strokes, diabetes. So make sure that you have a good health plan. Make sure that you're being vaccinated like you should be. Make sure that you take in a very good diet. You have activities that help you as far as exercise, and looking at all types of activities like yoga, relaxation, gardening, traveling, all of those things. And again, I encourage persons to explore complementary and alternative medicine, because again, that might be another way for you to take ownership of what you can do in a holistic way for your health. So again, health promotion strategies, make sure that you have those written down. They should help you satisfy personal relationships. Get a strong support network to help you out. Fulfilling work, leisure activities, a meaningful place in the community, and adequate attention to one's inner self. So very important when you're thinking about wellness to do these things. So the concept of self-management, again, comprehensive care really is you being an active participant, leading the team. So it's important that you start thinking about taking responsibility for doing what it takes to manage illness effectively. Going to see your healthcare provider when you need to, doing the things that you need to do, but also taking your therapy. Individual and healthcare providers are partners in your care. We can't do it. We need you to be there to do it. Discuss different treatment options. So if something's not working well for you, make sure that you have that discussion. Self-management support is the care and encouragement provided to persons with chronic conditions and their families to help them understand their central role in managing their illness, make informed decisions about care, and engage in healthy behavior. So again, very important. So when we look at self-management, some key things for you to do, obviously taking medication, adhering to your treatment if you can't, keeping medical appointments, maintaining a healthy lifestyle with diet and exercise, continue normal activities at home with family and friends, work and leisure, work on adapting to the disease, work on retaining the ability to look towards the future. So hopefully that you're always able to do that. And again, if you're not, then this is something that you need to identify for your healthcare provider. Moving towards self-management, again, understand that you have some experience living with MS. Learn and gain from that. Gain knowledge and confidence from not only what you've been through, what you can share with others, and what you can get from others. Be involved with your healthcare providers. Seek two-way communication. I tell persons in this area, we are very blessed to have multiple sclerosis specialists, 3 different centers in this area. So if you're not getting what you need, please don't stay, go find another one. It's easy enough to do. Again, employing strategies to stay healthy. So here is a checklist for comprehensive care. If you see things that are not in the place that you go to, write these down and say, hey, where are these things? But these are the type of things in a comprehensive care that we look for, that persons are having these opportunities. So again, we've discussed this in great detail, but again, more a team-based intervention, very holistic, and coordinating healthcare services. And so some insurance companies say that they have this for you with a nurse or someone that calls from the insurance company. But again, sometimes you have to make sure what is the motivation there. If the motivation is not you in the middle, then that person might just be looking at how they can save your insurance company money. So be careful. The motivation should always be you in the middle. So in summary, this MS is a very complex disease. It's unpredictable. There's a variety of symptoms. It impacts you in so many ways and your family. It's widespread, long-lasting, affects you, your family members, and your community. Comprehensive MS provides a broad spectrum of services that can enhance your self-care and your quality of life. And my biggest thing here is that this is not a sprint. This is a marathon. So this is a disease that is yours. Embrace it and do what you can and keep learning. I'm so happy to see you, so many of you out here so late at night. So thank you very much for coming out.
Thank you, thank you. That was great. So now we're going to bring up Dr. Koenitzer, and Patricia and Dr. Koenitzer will both be doing the Q&A at the same time. So whatever questions that you have, first raise your hand, let me get out to you. And then also, please just say, this is for blah, 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 okay? I'm going to start here only because he's right here.
Patricia, you know, I, for one, I'm sick and tired of being sick and tired. I really am. It's getting to be unbelievable, as you said, to make this your full-time job to manage this disease. I spent 6 hours today managing my disease because one doctor changed the appointment on me, and I can't get follow-up doctor visits with that doctor for 4 or 5 months. And then that changed everything down the road. They get bladder issues. You know, we are limited as patients. We're limited by our insurance. Would I have liked to stay with your practice? Of course. Actually, if it wasn't for nurse practitioners, I would have no care at all. True. You don't get to see doctors in some of these practices that you said, or I know you're saying that they're MS centers. I'm sorry. When you can only get to see that doctor once or twice a year, and no matter what, you can't get back in to see that doctor again, no matter what's going on with you, that's the wrong way to do it. I couldn't get my Ocrevus this year because these doctors are too busy. Not just MS neurologists. Every doctor in this damn city, and I'm moving out of it, so thank God, but every doctor in this city is too busy for us. They are booked months in advance. So what can we do about all this? I mean, I don't even know if there is an answer, but I'm really sick of it. I am. Like I said, it's exhausting to manage this disease.
So, you know, again, I feel extremely disheartened when I hear what you say. For one, you know, I value the place that I fit in the practice that I serve in, and as many persons that I have that, believe it or not, there's a person or two that comes in and says, I only want to see the doctor. There's many persons that walk in and say, I don't ever want to see him, please don't, you know. But we work, nurse practitioners, in a collaborative relationship with a physician. The state does not allow us to work without a collaborating physician. Although we have more abilities to write and prescribe things than we ever have before, we still have to have that collaborative relationship. And so if you come into our office and you want to see the physician, that should be an option for you. And I apologize if it never was, but all I can tell you is you need to find somebody to help advocate for you. If you're tired, what can you do that you didn't spend 6 hours? What can you do to have someone? And so maybe you need to call MS Views and News, their social worker. What is it that they can do for you? Call your insurance company. What, you know, because, you know, I'm waiting for somebody, and I've said this many times, I'm waiting for somebody to take a class action lawsuit against some of these insurance companies that are not allowing persons to have what they need. So again, I feel bad for you, and we're not supposed to be giving medical advice to one person, but look for resources that can help you out. Again, a collaborative team, so I would tell you psychologists even might be able to help you make a list of how you get through these things.
So going forward, we got to try to keep things generalized and not about you. You know, you can't ask a question about yourself because, number one, you may not be Patricia's patient, but number two, if you are, she's not allowed to disclose anything. So just make everything general, okay?
I have two quick questions.
You're allowed one, then you have to pay for the other.
I took pictures, I paid. You had symptoms. You had a secondary symptoms as falls and urinary tract infections. But don't urinary tract infections cause things?
Okay, so urinary tract infections, when you get an infection, you can get an elevation of your fever. Your central nervous system, again, works overtime. And so you can have symptoms that happen because of that urinary tract infection. But those are symptoms that are not new lesions. Yes, they're from old lesions, but it's not something new that's occurring, and it's, again, just slowing down the damage that you already have. Urinary tract infections can be a part of a therapy maybe that you're on that puts you at higher risk for that. So again, if that's a problem, then you talk to your healthcare provider about, is there something that you need to do special for that?
And the other one here, I'm embarrassed to ask here, on the sexuality thing, you had a bag of peas. What do you mean by a bag of peas?
Oh my God, you don't know that?
No, I don't. Frozen.
Not getting there.
You were all confused by the bag of peas. Okay, so
You're on.
so nobody read 50 Shades of Grey? Nobody went to see the movie The Book Club? Oh man, you guys are really okay. So for females, you can use that bag of peas and insert some of them internally to stimulate yourself. There's other ways that you can use you put some of those peas in your mouth if you're pleasuring your male. So there are many ways that you can use that bag of peas. That's okay. You just want to know if I knew that.
I also have two questions.
Okay.
The first is it even possible to reduce the number of lesions through medication?
Very good question. So anytime on an MRI, we can see lesions that come, we can see lesions that go that are less apparent, and then we can see lesions that get larger or progress to where they're a black hole where there's no brain tissue. What we don't know is that in any area of the brain, there is a percentage of tissue, unless you're talking about the black hole, that there are some perfectly normal, healthy neurons, and then there are some that are damaged. So we would speculate that in an area where there's a scar, there's more damaged neurons than there are healthy ones. But we've also taken biopsies of areas that look perfectly normal on an MRI and seen damage in that area. So could that have been a lesion that occurred and then there was enough healing that we can't see it on an MRI, but you still can have damaged neurons. But yes, the answer to your question is lesions can become less or go away.
My second question is, you had mentioned stay current with vaccines. So flu, pneumonia. Can we have the shingles vaccine?
I don't recommend any of my persons get live vaccines, although the data on live vaccines, if you were to look at the meta-analysis, that does not bear out in research, the meta-analysis of that. So you have to talk with your healthcare provider about live vaccines. But yes, the flu vaccine and the pneumonia vaccine, which are dead or inactivated vaccines, you should get those on a regular basis. The flu vaccine has the opportunity to get a shot or nasal. Go with the shot because the nasal is a live virus. So you should, yes. If you are on a disease-modifying therapy, please make sure you do ask your healthcare provider, because some of the cell-depleting therapies, there might be different recommendations. So, make sure that you're checking with your healthcare provider about that.
There is a new dead virus shingles vaccine that is available. It's given as 2 injections 4 months apart.
I've heard that, but I haven't been able to have anybody find it in Orlando area. So
it's available. It's a very backordered in many places.
Okay, so it's coming.
Okay, question for Dr. Koenitzer. Many MS patients have a baseline study done for cognitive issues, yes? When do you recommend that a patient has maybe a second one, how many years in, just to see if their cognitive decline has gotten worse, or is there no decline, or whatnot, but just to see, their processing speeds or whatnot. Do you recommend that a person have one again?
Sure. So there's a couple of bullet points to answer that. The first, I'll say, just technically speaking, depending on where you go, but more or less in general with neuropsychological testing, your brain has an amazing capacity to remember the general aspects of the test, such that we say about 12 months is a necessary threshold for any retesting. And people will tell me all the time, trust me, I don't remember that test. I don't remember. But your brain remembers the general process of the test, some more or less. And so you'll do better within 12 months just because of something called practice effects. So the short answer is we don't want to be testing people within 12 months on a full battery of tests. But, right, so we get a baseline. Medical necessity is the next bullet point to the answer. If someone comes, they get their baseline, and we say we recommend re-eval 18 to 24 months, or if there are any acute changes in functionality or perceived cognitive decline, come back then. So it's outside of the 12 months. You go back to Tricia or neurologist or where you're getting treatment, you say something's gotten worse, and here's what it is. That would be the time to go back and get something to compare to the baseline. See if we can take a Polaroid of an exacerbation, a cognitive exacerbation, and compare it to baseline. That would be wonderful. But not before 12 months in general.
Thank you.
First of all, Dr. Justin, what is the color on the back of your suit?
I never answered that, right? Alex gave the answer. Okay. And so there is no sticker on the back of my suit. She knew it. And if you remember, and you probably don't because it was a long time ago, but the point was that if you don't pay attention, how dare I ask you to remember? To illustrate the point that memory is not a thing, right? Remember, it's a process. It starts with paying attention, and because no one paid attention to the back of my jacket, you didn't know you had to, then you didn't internalize it so that I could ask you, do you remember it?
Okay, thank you. Dr. Patricia, I just want to ask one question. One more question. What causes tremors, and what medication can treat those? Can you do something yourself and function again?
So tremors are caused by lesions in your brain, most often in your cerebellum. And so there are medications, and of course in other disease states like Parkinson's and essential tremor, it's a degeneration of a different area of your brain. So there are medications that you can take that will help with those, beta blockers if that's appropriate. There's seizure medicines that you can take. But with tremors, the very first thing is stress management, relaxation, deep breathing, and don't do anything that's stimulating. And if your tremor only bothers you when you're in stressful or in situations where you have to perform, you might need to recognize that the goal of giving a medication is to reduce the severity and frequency of tremor. But if you put yourself on the hot spot, the medication is not going to take away that tremor. So if you are looking for a medication that when you go in and you have to present to the classroom of individuals and you don't want to be writing on the chalkboard like this, if you're not real comfortable and it's not a place where you're been a million times, you're probably going to have some tremor. So it's thinking about that.
Yes, you said smoking exasperates the MS. If you are a smoker and you find out you have MS and you stop smoking, does that improve it?
Does not improve it, but it will make, again, your progression will not be as quick as if you don't. So smoking is one of the things as far as environmental factors that put you at higher risk for developing MS. So once you develop MS, the goal is to do everything you can to slow the progression. And since smoking will enhance the progression of your disease, stopping smoking will help you not progress as fast, but it won't take away the fact that you have been diagnosed with MS.
So going back to Dr. Koenitzer again, what memory games do you recommend for people to do to enhance their thoughts, their processing?
It's a great question, and similar to Tricia's answer with ginkgo biloba, there is just not enough compelling research. And, we're science people, so we have to read enough and see enough to say, okay, finally there's a consensus, go out and buy Luminosity, and play that computer game. As far as I can see and from what people tell me, the only way that some of these brain games that are offered online for a price will hurt you okay, is if they give you some sense of false hope that they will cure your memory issue. That's a legitimate hurt, false hope. And then also they might hurt the back pocket, is some of them are quite expensive. So that's why we can't say this brain game is going to work real well and going to change your life. Go out and spend $500 on it that you might not have and do it. Outside of those caveats, I think anytime you're exercising your brain in a game-like fashion, if we get real general with this, is probably not a bad thing. But hear how I said that. I'm not saying that we have evidence that it's going to change your MS. It's probably not a bad thing. You're exercising your brain cells. One of the biggest things, it's not memory, but believe it or not, because of that cognitive model I showed you, will help globally, may even help you feel like you're remembering better, is reading. Language-based skills activate mainly the left temporal lobe, but they're language skills activating networks of words, and then those words activate networks of concepts. And so the more rich your brain is in that type of activation, the better you feel cognitively in terms of being have intellectual prowess.
What about for those that just simply have a deck of playing cards and to whip out the game called concentration to just mix up your cards and figure out where your numbers are?
Do it. Do it over and over again, and do it with people.
Okay, great. Thank you.
For Patricia, I believe. Is there a study worldwide on MS? Is it cultural, environmental, genetic, let's say hemispheric?
Are you talking about the incidence of persons getting multiple sclerosis? So we do have worldwide data on who is more likely to get the prevalence. And so persons who live further away from the equator, all around, persons who are Caucasian are more highly likely. Persons who are women versus men, persons who have been exposed to the Epstein-Barr virus, that is a risk factor, persons who were obese as adolescents or had high salt diets are another. And so those are some of the big caveats. In North America, we have NARCOMS, which is an organization that collects data. So there are organizations that are collecting data worldwide. So that's, you might be in a higher risk category, or you might have someone in the family who has multiple sclerosis. We know that there are 156 genes now that put persons a little bit higher risk. The problem is we can't say that if you did this and you have this gene and you were exposed to this virus, you're definitely going to get MS. So we know things that put persons at higher risk. Good question.
We only have time for 2 more questions. It is approaching 9 o'clock.
For Dr. Koenitzer, so the game question?
Yes.
How does that contrast to biofeedback, which is supposed to train and remap the brain, which is essentially a brain game, right? For a very simple explanation.
Yeah. There's a lot of similarities, and in the interest of time, I'll say it's a great analogy. Biofeedback is typically used more for states of mind, for relaxation, for conditioning yourself to be in certain states of less pain, less anxiety. Those are the main 2 that we use it for now. So it's not necessarily instigating an intellectual side, in fact, maybe doing the opposite, quieting the brain. But in a very same way, you're using tools that are interacting with the world in your brain to change your brain. General enough. But yeah, I gave a talk on MS and pain a while back, and we talked about biofeedback. It's a real good option.
Last question.
Are there any medications that you can take, especially for the brain to remember, like they give to the Alzheimer's? There's a lot of medication. I don't see if it does any good or not.
This is a great question to finish out on with both Tricia and myself, maybe throwing an answer out. From what I've seen in the research papers, there's a drug called Donepezil, which is probably the leading go-to medication for Alzheimer's. It's used sometimes in vascular related cognitive disorders, and off-label in some others. Aricept, you may have heard of, or Donepezil. So far in the MS research, it's mixed, and overall, the last paper I read concludes that there's not enough evidence to suggest that it's all that useful for MS. And it has a lot to do with the mechanisms of the drug and the neurochemicals that it affects in relation to Alzheimer's versus MS. So that's for that one. There are some other drugs that are used. I keep going back to Alzheimer's because that's the staple way to talk about it. They're called cognitive enhancers with similar results. They're mixed. Some studies say they're useful in MS, not too useful. Others say they aren't. And in terms of the disease-modifying agents, there's been some studies looking at, do they globally improve things to include cognition? And there is evidence that they can, but there's also studies that suggest that there's less of an effect. In fact, even some that say there's not really any effect at all. So that's kind of the unfortunate state of affairs, is we don't really know. There's some evidence for, some evidence against. The overall guiding recommendation from my subspecialty, at least, is to suggest that there's not enough evidence to be prescribing this routinely for this condition.
And from a perspective of a person who treats the disease from a modifying standpoint, from a disease modifying standpoint, I would tell you that that is one of the things that you need to be very aware of where you are on your therapy, because these invisible symptoms. So persons recognize if you're walking a little bit differently or your balance is not as good, but many people may not recognize some of the cognitive difficulties you're having, and then maybe you don't bring that up with your healthcare provider. And so again, recognizing that that can be a symptom of your multiple sclerosis, and if that is progressing, then potentially the disease-modifying therapy you're on is not continuing to work. So there is a risk of this disease. There is a risk of medicine, but you need to constantly be balancing. If your disease is still active in any way, then that's an opportunity for you and your healthcare provider to talk about, am I doing everything that I can? From a comprehensive standpoint, doing everything you can is, yes, treating your disease with a disease-modifying therapy, but we know through Alzheimer's and other degenerative diseases, what will minimize brain atrophy and minimize cognitive difficulties is physical exercise. Physical, aerobic exercise, getting your heart rate up, aerobic exercise, and cognitive training. And so there's lots of things, as Dr. Koenitzer says, there's lots of things. But one of the most important things is staying in the game, not retreating, not going in and not being involved. Having a conversation with another person is very cognitively stimulating. So those of you that are here with your spouses, your care providers, do your partner a favor. Do not guess what they want. Make them ask for it. Don't answer questions for them. Don't finish questions for them. Make them speak, make them talk, and try to get them to tell you about their day. Talk. Be social.
So, thank you, everybody. These guys are great, right? Patricia, thank you very much. Justin, thank you very much. Jeff, thank you very much. And y'all, thank you very much, all right? We can't do these programs without you, so thank you for coming down. Thank you for being here. And just ask for us to come on back again, all right? Again, I want to thank Celgene, I want to thank Genentech, and I want to thank you all for being here today. Hoorah, let's go.